Okay. For lipid management, last year, 2013, ACC, AHA came out with the guidelines, and guess what? They tell us we're going to have to give moderate intensity or high intensity statins, like a strong statin or not so strong statin. And we're going to give those to patients based on certain risk factors. So they want to tell you which patient you're going to give them statins. There is 4 groups of patients eligible for statin. And those are any patient with clinical atherosclerotic cardiovascular disease, somebody who had problem with strokes and cardiovascular thing, you're going to give them statin. Any patient who have LDL more than 190, you give them a statin. Any individual, any patient with DM or diabetes mellitus and age between 40 and 75, they're going to also need a statin. Any patient without ASCVD or diabetes, but they do have a risk factor, 10 years risk factor for cardiovascular diseases more than 7.5 are eligible for statin. If you missed it all, the 4 groups who can benefit from statins is clinical ASCVD, a primary elevation in LDL more than 190, age 40 to 75 with diabetes, and their LDL between 70 and 189, age 40 to 75 with LDL between 70 and 189, and that having a 10-year risk of 7.5. Where do you get the 10-year risk from? There is a calculator. I'm going to show where is the calculator at. There is a link of it in your online course. But simply it is a calculator. You put patient gender, age, race, total cholesterol, LDL, HDL, blood pressure, systolic, diastolic, whether the patient have diabetes or smoker. And if that number is more than 7.5, then that patient should be on statins. So that's how they get that from. And of course, it depends on sex, age, race, total cholesterol, LDL, systolic blood pressure, and so on and so forth. Yeah, that's one important for us. Statins. You all know the statins, right? Anything with statin is the end of it. Look at atorvastatin, which is Lipitor, or rosuvastatin, which is Crestor. These 2 are in a league of their own. A league of their own, this means high-intensity statin therapy. So if you got a patient who need a high-intensity statin, one of those is the drug. If somebody needs high intensity, then you use atorvastatin or rosuvastatin. You cannot use pravastatin or simvastatin. For moderate, you can use any of those. For low intensity, use any of those. So really, the biggest thing is if you have a patient need high intensity statin, you want to give them either Lipitor or Crestor, and that's why we see tons of them right now. If the patient needs just moderate intensity, then you can use one of those. That one compare what's the difference between most of the statins and their efficacy. And like you see over here, the lower dose get you somewhere about 30 to 40% effect. And you can gain maybe about 10 or 20% increase in efficacy by doubling or tripling the dose, which really is not worth giving too much of a dose if you're going to risk a side effect. Okay, those one is the algorithm or the chart for it. It will tell you patient if they do have ASCVD, definitely you want to give them a high intensity statin. If patient does have diabetes and their risk of 10 years is more than 7.5, you're going to give them high intensity as well. Yeah, the biggest thing in the new guidelines, you don't treat to a target. Before, and I think we still use that for diabetes, we say, well, the LDL has to be less than 100, the triglyceride has to be less than 150. Those guidelines, they don't address those. And this is the Flausen's guidelines. Not everybody is universally adopting them, but be aware they are there. What they actually did, they classify patient who can benefit. They say if the patient have history of cardiovascular diseases, then they needed the high dose of that statin, high potency statin to give. And if the patient have diabetes with higher risk, you can give them those statin as well. So they don't treat to a target anymore, and they just classify patient who need a statin into 4 groups. So if somebody come out of the street, I got LDL is 190, you're gonna go ahead and get statin. I don't have to look at anything else like I did before. And once I give them the statin and they taking it, tolerating it, there should be no problem. I don't come back and say, well, I want to check your lab work to see where you at, and we're going to adjust. You don't really adjust based on that. You just look to see what the success of therapy is. So what they do, they just start you at a certain dose based on your 4 category called 4 benefit groups. And once you are there, they adjust it from there, but they don't treat to a target anymore. Okay. Blood pressure is another one. Came out, and the quick on that one. It's supposedly simplifying. I don't know if you have that handout there or not, but we'll go over that algorithm quick. Look at it. If you are less than the age of 60, the target goal to treat you for your blood pressure is 140/90. If you are more than the age of 65, then we go easy on you because we're going to get side effect if we're going to get strict on you. So your target goal is 150, less than 150 over less than 90. Patient who have diabetes, chronic kidney disease, the goal is less than 140 to then less than 90. Of course, it's different from the ADA guidelines. It's saying 130/80. Patient with chronic kidney disease, the goal is less than 140 and less than 90. And look at here for medication. What medication do you give? If you have patient who are black patient, they need to be started on thiazide and calcium channel blockers. Okay, if they have diabetes, you might want to add ACE inhibitor. But anybody, regardless of their age, regardless of their race, if they have chronic kidney disease, they need to be started on ACE or ARB. And that's a little bit different than what we are used to. So those are the new, and this is the JNC8. They just released, and they are not actually look anything like those one we had before. But I will go over here and see if I can bring that slide quick to show you those apps. Okay. JNC versus JNC7, the 8 versus the 7. We treat to 150 to less than 150/90 in patient over age of 60. Everybody else, the target is less than 140/90. And there is 4 classes of drugs they only give. One of them is going to be thiazide diuretics, one is calcium channel blockers, and one is ARBs, and one is ACE inhibitors. That's all what we got. This is the recommendation there, but the answer 3 questions, when do we start the medication, what level or target we're going to treat the patient for, and then an adult with hypertension, what's the difference between those ones. So age of 60 or older, if they have blood pressure more than 150/90, then the goal is to bring it to less than 150/90. For less than 60, it's less than 140/90. Those are the 4 classes of drugs now. thiazide type diuretics, the calcium channel blockers, the angiotensin converting enzyme inhibitors, ACE inhibitors, and ARBs. For black population, thiazide and calcium channel blockers would be how they start them with. They can add ACE inhibitors if they have the diabetes and kidney disease. Those are different comparison between all this population. The only thing I don't have time to go over it, is going to be diabetes guidelines. I put the slides up there. I put the guidelines up there. But before I finish the meeting, your patient who is diabetes, they can benefit from the AADE7 behavioral goals. Here is you needed to know the two major targets we are looking for in patient with diabetes. We are looking for A1C less than 7%, according to the ADA. We are looking for a blood pressure. Now they say it's 140/80. And we are looking for the triglycerides less than 150, the LDL less than 100, unless you have a cardiovascular risk factors, make it 70. Total cholesterol is less than 150. Of course, you look for the patient BMI and trying to help the patient lose weight. So those are more or less the criteria for target for patient with diabetes. Your glycemic control, the A1C 7% or less, your blood pressure, and your cholesterol or lipid profile in there. I don't really see a whole lot of a change in those guidelines from the past, but mainly you're going to see those patients, make sure they get ACE inhibitors. You want to also make sure those patients will be able to take their medication. They are motivated enough. And one important thing, remember, chronic disease condition is what we are trying to improve. And we cannot improve those unless the patient agrees. So the bottom line is you have to motivate the patient. We cannot say, okay, you're not doing this, you need to do that. It's not going to do it. We are in the patient watch. If the patient are not agreeing to the change, it's not going to happen. All right, any questions for me? Did I bore you guys enough today? Sorry. Learn anything, motivated to do anything? Okay, well, this is the beginning. Just keep in touch, and we'll, let's say we finish up. There's test there, you take the test. There's a form, evaluation form there, you fill that out, and we'll send your certificate as well when you finish those. I will tape the diabetes slides, the one I didn't finish, so it will be available for you to review it online as well. If you need anything at any time, just let us know. I also would like to thank Samir. He's running the medication center in Grundy, and also Michael helped us a whole lot with the work we have been doing. And both of them here today committed to help you. So the bottom line is we are in your team. So we're going to be a part of your team. We're going to help you in a way we could. You can count on us. We're one phone call away or one video hopefully away someday. But yeah, we'll help you in a way we could. And also would love to have you to help us with what we're doing. You've seen some of the screen. I got 168 patients a week to do tips for, and I don't think I can do that on my own. So we're probably going to be calling on you if you're interested in helping us finishing some of those cases, and we'll pay you for it. So that's the whole thing. At your store, your pharmacy, hopefully they will be paying you for what you're doing there. But again, we will be more than happy to help you there as well. And we will like to have you to help us. And we would like to be able to call on you if you have time and you have the will or desire or motivation to help us, because I think it's huge, bigger than us, and we think we can need the help. And I think we have a good start. We got good group of people motivated. We got infrastructure ready to go. And thank you very much. And please take some cookies with you, take some drinks with you. I'm not planning on taking anything home.